for tonight for this very awesome event. We're going to be talking about two important topics, which is fibroids and fertility. And we have two really amazing reproductive and healthcare experts that will be speaking upon this tonight. So we have Dr. Brian Levine from CCRM and Dr. Phil Hart from Conceive. So we'd love for you guys to introduce yourself to the audience for everyone here tonight.
Sure, thank you, Jen. So my name is Dr. James Gohar. I'm practicing OBGYN. I'm also the CEO and co-founder of BBD. Thank you so much for having me tonight. Thank you for everyone who's attending today. And also my colleague, Dr. Levine.
So I'm Dr. Brian Levine. I am a practicing reproductive endocrinologist and fertility specialist. I'm a fertility doctor for everyone else in the world. And I do three things at a place called CCRM, New York. I help people get pregnant, I help people stay pregnant, and I help people protect and preserve their fertility. But tonight's topic of fibroids affects all three of those groups, so I'm super excited to be here. So thank you.
Thank you guys. And so for you guys, if you don't know, they're both of my doctors. I've seen both of them. And they are amazing. They have wealth of knowledge and information. And a lot of these things can be a little scary, fibroids and fertility, and just sharing things sort of puts you in a very vulnerable place. And so I think it's really nice to have them here. They have a lot of information to share with you guys. So before we dive in though, can you guys give us a quick overview of the differences between REI, which is reproductive endocrinologist, and OBGYN?
Sure. Yeah, I think it's interesting because I think the way Dr. Levine described this practice and this area of focus is very concise, very clear. I think women's health for us is a much broader topic. I think OBGYN in many ways is a combination of both general, what people mostly associate with primary care, as well as specialty care. And so pretty much every fertility doctor, at least in the US, has to be an OBGYN before they become a fertility specialist. They subspecialize in fertility after doing the same training that we do in OBGYN. So there's a tremendous amount of overlap. And it's not so clear sometimes where those lines begin and end. But what I would say is that in general, most women will often get care on a regular basis from an OBGYN, but not necessarily get regular care from the fertility doctor. They'll go to the fertility doctor, and we will often facilitate that. We work in collaboration. We have terrific relationships with people like Dr. Levine, who we ultimately would want to lean on whenever we have specific circumstances and situations that warrant a higher level of specialization in that particular area. Let's say, for example, if a woman has issues with her pregnancy, or issues with birth control or fertility planning, all those other things that are part of that ecosystem, that's more within the OB/GYN's work.
Sure. No, it's I always joke is that we did 4 years of training, and during those 4 years of training to be an OB/GYN, it was amazing. I loved delivering babies, but I also loved stop delivering babies. And I'm glad there are people like Dr. Gohar who are willing to still do it. But then I spent another 3 years becoming basically a hormone doctor. Right? So fertility doctors are really specialists in reproductive endocrinology. That's really the bulk of what I do for a living. The infertility has just been the side piece that so many people have now made their entire careers. Right? So a fertility doctor really is someone who's trained on how do you deal with the reproductive hormones. How does the brain talk to the ovaries, and how does the ovary talk to the brain? How do your hormones stay in line or not? But the gross majority, over 85% of fertility doctors in America who are reproductive endocrinologists do fertility mainly. Again, some of us do help treat people through menopause, and that's an important topic I'm sure we'll hit on tonight. Specifically, I have an area of interest in young women who've experienced menopause, which is something that we don't really talk about very often, because those are some of the toughest fertility patients to treat. But also, in this day and age, we talk to people a lot about transgender needs and how do we actually treat people in the community where they don't know even where to start. And a lot of those conversations surround hormones, which again is what I do every day.
Awesome. Thanks for sharing that. I didn't really know the specific details of what the differences are, but it's nice to know because I know even coming here to BBE, depending on what the patient needs, you guys are great for providing them with this general, it's like all things you need for women's health care. And then for specifics, if they're interested in fertility, you work alongside CCRM and Dr. Levine as well. It's just this really good relationship that you guys have.
Yeah, absolutely. I think at BBD, we see ourselves as women's health, and so it's a more broad there are definitely areas of expertise that we've developed over the years. Fibroids certainly has been one of them. And there are a lot of other specialists that are involved within our group besides just OB/GYN. But speaking in general terms between how it often works between OB/GYNs and the subspecialties within the field, our experience and our relationship with fertility or reproductive endocrinology is very similar to our relationship with other subspecialties within the field. So, for example, GYN oncology is a subspecialty within GYN. Urology or urogynecology, specifically when we talk about women's health, is also a subspecialty. Minimally invasive GYN surgery has now become a subspecialty within OB/GYN. And so these areas are essentially very common problems that we find within the general sphere of OB/GYN. But then when there are more specific, deeper problems that require a deeper area of expertise and specialization, then we will often work with folks like Dr. Levine in order to make sure that we give the best and most up-to-date care to the specific patient in that specific situation.
So that brings us to the next topic. Many don't really realize that fibroids and fertility have a lot in common. Coming into just learning a little bit more about the women's health, I actually didn't know what fibroids, what it meant. So could you guys tell us what fibroid, what causes fibroids, what the basics are?
Sure, I'm happy to take it. I think fibroids are essentially benign muscle cells that go haywire within the uterus. The uterus are muscle cells, and we don't know exactly why. I think there's all sorts of theories in why. We often say to our patients that that's a more philosophical question than a scientific one at this point, because we really don't know. We know it's more common in certain women. We know it's more common in certain families, certain ethnic groups. I think the statistics show that, for example, Black women are 3 times more likely than non-Black women to get fibroids. But it's not specific just to one ethnicity. It's actually very common across the globe, across the world. Numbers show that as many as 30% of women by the age of 35 will have fibroids, and 70% by the age of 50 will have fibroids. So it's a remarkable number of people who are impacted by this condition. But funny enough, we still haven't found a gene. And I think one important point where we talk about this, just so it doesn't sound alarmist, not all fibroids need to be treated. There's a significant percentage of women who have fibroids that don't bother them, that we can manage conservatively and just keep an eye on.
That was, I think, an excellent intro to fibroids. And, fibroids are very much like New York City real estate, like location, 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 right? So, no matter where they are, if they're relevant or not. What's amazing to me is that as a fertility doctor, part and parcel of my evaluation of nearly every single patient is an ultrasound, right? So a picture's worth 1,000 words. And so when I view a patient, of course, I want to talk to them, get to know who they are, know why they're seeing me, understand what their expectations are, and what they're hoping to learn that day in that visit. But most importantly is to have an expectation of what they are prepared to hear or not hear at that time. And I don't think a lot of people check the pulse of the patient, both literally because, right, when's the last time someone asked me to do CPR? I never check pulses. But literally, check the pulse of, what does the patient want to hear? What are they prepared to hear?
So true.
And I cannot tell you how many times I do an ultrasound for a patient and I say something like, oh, you're in the 20% of the population where your uterus is bent backwards. That's called retroverted, completely normal. Or, oh, you have a fibroid in your uterus. And it's at that moment when the patient's in front of you and they have a paper towel over them and all of a sudden there's an ultrasound going on, they're like, what the hell is a fibroid? And the last thing you want to say to them is, don't worry, it's a tumor, but it's benign. Right? Back to kindergarten top of Arnold Schwarzenegger, it's not a tumor. It is a tumor. It's a benign growth that's in the uterus. And what I explain to people is sometimes it's a pebble. And it's just like that old story that we read to our kids, the pea that's under the mattress, and no matter how many times you stack it up, you still feel it. Well, back to what I said before, it depends where your fibroid is, how big it is, the type that it is, not if it's relevant or irrelevant. But you should all know as patients that the two of us in our practices are completely aligned in transparency. Right? So it's all about being transparent with patients and helping them understand about their bodies, so at least they can go home and if they Google the right things. I find that we de-Google patients a lot recently, but hopefully they come back better educated, understanding about their bodies and about things like fibroids.
And then those are good points. Do you normally, as a woman, do you feel the symptoms of fibroids, you may not, or is it more common that you actually don't even notice that you have it?
So, I'm still waiting for my period, so I have a hard time talking about it. But I do talk to people every day about their periods. And to be quite honest, I think sometimes it's like the keystone for what they've not been able to put into words for so long. Pelvic pressure, fullness, irregular bleeding, pain with intercourse, pain with their periods, pain that doesn't go away sometimes when you take medication, bloating, an extra pouch in the front, feeling like they're extra constipated in the back. Like there's all these different symptoms that seem so vague, so almost nondescript, then almost like it becomes this moment where like, oh, thank goodness they found something. And I think as a society we're really bad about talking about things that like we don't view as like dinner table talk, right? Like we don't talk about like painful intercourse. We don't talk about like someone who can't wear white jeans every Memorial Day. That's what we do all the time. Like someone who has irregular periods and can't predict their periods. Like, we don't talk about these things. And if we did, I bet you as a society we'd bring up like many of the key symptoms with fibroids.
Look, I definitely want to second everything back to what you said. I couldn't agree with you more. I think people don't talk about these things enough, and I think there's a stigma for some reason for some women and some patients that we hear pretty often. And I think, the other point that you're making, I think, is that it really can vary so much from person to person, right? I mean, you have we have patients of ours who come to us with literally fibroids of the size of melons or large fruit, oranges. And we have other women with literally pebbles or tiny small areas that you can barely notice on imaging. And you can find patients with much smaller fibroids complaining of significantly a lot more symptoms, a lot more pain. And the opposite is often true. And there's a big range of variation there. And we see this with a lot of conditions of medicine. I think endometriosis is another great example of that, which Dr. Lee can speak to as well, where the amount of disease that you see does not correspond in any corresponding way to the actual symptoms that the person's having. And so it's sometimes confusing for patients. And sometimes patients will, discount or be told that, hey, this fibroid is no big deal when it's quite small. But in fact, the symptoms based on the location or based on a whole host of factors really is creating a big difference for them.
And I will just add, it sounds weird to say it, but a lot of people don't talk to their mothers about these things. And so your mother probably had very similar symptoms because we know that there's a 3x likelihood of having fibroids or myomas. That's the other word we use to describe them, myomas, which basically is like the Latin word for muscle cells. That if your mother had a fibroid, there's a 3-time likelihood that you're going to have fibroids in your life. And imagine if your mother just said at one point, when I was in my 30s, I got really anemic. So as I was chasing around you and your sister and you were such pains in the butt, imagine how I felt when I was almost passing out. That would be a very different story if you knew that. You just thought your mom was cranky. And so, if you had some context on why she was so cranky, why she was bleeding, maybe when you turn 35, you'll start thinking about this. You won't think there's something wrong with you, but this is part of your family history.
Yeah, and I'll just even touch on that some more too. I think that one of the biggest, challenges with fibroids is it essentially turns people into, let me just describe it in the opposite way. I think when someone has a problem that's really affecting them, like any of us, right? Whether it be, a headache, whether it be a fibroid, whether it be, whatever equivalent of the pee on the mattress that we all tend to have, right? We don't actually function in an optimal way. We're not the best version of ourselves we can be, right? We're not as patient as we are with our kids. We're not as thoughtful and understanding of our spouses. We don't tend to be as patient as we ordinarily would be. And all that has a downstream impact. And if you really think about what many women are in their families, I think I often have this conversation with my own wife and with with many of my patients, is that many women are the glue of their family. They're the glue of their surroundings. And so when you think about someone who has to be a mother, has to be a friend, has to be a sister, an aunt, a daughter, when someone isn't feeling very good about themselves, when they're not able to get to work very often, when they have to call out, not able to get to the gym, be intimate with their partner and be comfortable and not have it hurt, all these things have such a downstream impact on the people around them and not just that person.
Yeah, it must be tough to be a woman, right? Well, women women show up, and I think that there's so many amazing things that, especially when we go through within their own bodies, and they do to help with the family and support the family. And I think that it's, taking time as a woman to think about your own needs and like understand your own body and what's going on is super important. So like when it comes to fibroids specifically, now that we understand a little bit more about fibroids, is there a specific age that it affects? Is it more for women who are during their like childbearing years or during menopause? Or does it just happen just depending on genetics, like you said, or the environment?
So I think it's a great question, and the answer is sure, right? Like it affects everyone differently. Now, the problem is that Google is a terrible place to start, but somehow everyone finishes their medical degree on Google, right? Like I don't mean the two of us here, like I mean you guys. And then you start Googling, you start getting to these weird places. Like, did you know being on birth control causes fibroids? Did you know birth control prevents fibroids? And then all of a sudden the patient comes to me and she's like, so does it cause it or prevent it? Because I want to be on it or I wasn't on it, or I was on it. And I'm like, let's just stop right there. Why are we talking about your fibroids today? Are you trying to get pregnant? Well, let's see, do we have bumps in the road, right? Is this creating a bumpy environment where an embryo wants to stay? Is this creating an environment where I think a baby will not be able to get out, right? Because we know that fibroids can grow dramatically in pregnancy. Is this something that's actually going to prevent you from getting pregnant, or staying pregnant? And the bigger question would be is, why do we need to talk about this today? You figure out the context of what the patient's really worried about, and you figure out if it's a problem or if it's the smoke where there's fire, then we start to make a plan. Part and parcel of what I do for the patient who's trying to get pregnant or stay pregnant is we take a look inside the lining of the uterus. There's a test we do, it's super old school, it's called a hysterosalpingogram. None of you will be able to Google that fast enough, I'm not going to spell it for you. You can just type in HSG. And HSG is also known as the dye test, DYE, because it's opaque dye, not DIE, that you're going to die if you do this test with you. But the dye test is basically where we put fluid inside the uterus and we take a bunch of x-rays. In fact, you can actually do them here. We don't have the machine to do it, but he has a setup here, he just showed me. And it's a very easy test where basically you shoot a bunch of x-rays through the uterus and you get an idea of the lay of the land. You get to see, is it a nice smooth contour or is there some lumps and bumps and abnormalities? If we see that, we'll typically refer them off to a GYN surgeon, someone like Dr. Billard, to go actually after them and shave them down or cut them out. Or sometimes we'll do it in our office. It's a very small procedure at the time of an egg retrieval. Regardless, the impact of fibroids is what is the function that's going on. And that's the most important question, is to say, why are we talking about it?
And so now that we understand that fibroids does affect pregnancy to some extent and fertility, can women with fibroids still have healthy pregnancies and carry through?
I mean, I view myself as healthy, and my mom said she had fibroids in pregnancy, so I think the answer is yes. But in truth, of course, right? Like, fertility doctors have only been around since the late 70s. People have been getting pregnant for much longer than that. And people probably had undiagnosed fibroids for a long time. I also think people have suffered with infertility much longer in silence than people recognize. So the answer is, of course, fibroids can impact your chances to get pregnant or stay pregnant. And that's why you need to actually see your OBGYN to get a proper evaluation.
Yeah, look, I agree. I think we talk a lot about the negative side of things. I think it's important to understand, just like the majority of women who have fibroids don't have symptoms. The majority of women who have fibroids won't have a problem getting pregnant. They won't have a problem getting pregnant. But there are certainly a sizable number who do have trouble one way or another. I think it's, as Dr. Levine was getting at, there's location, size, there's a whole host of factors that one would need to assess and plan for.
Well, I mean, back to what you were saying about going in and asking questions on Dr. Google. I know I came in and did that to both of you. So, I'm like, does coffee affect fertility? So, or like, if I don't drink enough water, what happens? If I'm too stressed from work because I'm like so busy, like, does that affect, like how your body responds? But what are some good questions that people should actually come in with or with to ask that are important?
So, and believe it or not, every question is important, right? So the one thing is, like, the root of the word hospital is the same as the root of the word hospitality, right? Like, it's a service profession. And there's enough doctors out there that people don't have to go to the person they had their appointment with. Like, they can leave, they can go somewhere else. So if we're not competing to have patients have the best experience possible, then we shouldn't be doing what we're doing. And I can tell you from my experience with patients in my practice, patients in his practice, like, we're always trying to improve every day. So if a patient ever feels like their questions aren't being answered or being minimized, tell us, because that's never the intention. With that said, the key question to ask a doctor, and it doesn't matter why you're there, if you're there for, you're going to go see your dermatologist, your endocrinologist, your cardiologist, any gist or whatever, or specialist, you should always just tell them who you are and what you do. Like, hey, I loved to work out, and now I can't. Or hey, I loved being able to go out partying with my friends, but I can't seem to recover the next day, and I am sunk for the week if I go out on Saturday night. Or, hey, every time I get my period, I gotta take a day off from work. Is there anything I can do for that? Because if you don't actually get at what's really bothering you, and you just dance around it being like, oh, what vitamin should I take? But you forget to tell the doctor that oh, by the way, I need to take a handful of Advil, and I literally am chewing them every time I get my period, which is so painful. We can't address the real problem at hand. So there's no silly questions is the answer.
Be honest, right?
Be honest, yeah.
Yeah, I think it's wonderful when you can have a really open and comfortable conversation with the patient, and I'm sure the same is true in both directions. I think that the foundation of good medicine is really having a good relationship with your doctor. I think that most doctors are in the field because they want to, and because they're in it for the right reasons. And I agree with Dr. Levine. I think if you're ever in a situation where you feel like you can't have those kind of conversations, you can't ask those kind of questions, you're probably not in the right place for you. And sometimes it's not that there's something wrong with the doctor or the place or you. Sometimes it's chemistry. And I think that, especially when we talk about things like, reproductive endocrinology or OB/GYN, these are long-term relationships. I have patients who I haven't seen in years. We run to the street or we run to each other someplace, and there's just an immediate connection. I'm sure the same is true for Dr. Levine. These are very personal, long-term working relationships, for lack of a better description. I have patients of mine who my mother was an OB/GYN, who my mother did, and who were delivered by my mother. And so there was just this generational, I think, relationship that I think is really unique to the area, to the specialty. And I'm sure Dr. Levine, once you've helped someone get pregnant, that's not something that they ever forget. And that's a conversation, that you can pick up, 3 years, 5 years, 10 years down the road without a hiccup.
I mean, the baby photos are the best, right? So we love getting baby photos. But I'll tell you the other thing that's amazing is the person who says, look, I froze my eggs, and I actually met the person I really loved. I didn't settle with the one that my mom was obsessed with because she was like, he's good enough. So just go settle with him, he's fine. We get the whole gamut of feedback from people. But yeah, the continuity of care is key, and I think from a big picture perspective, if there's any takeaway from this whole fibroid conversation, it should be that many people suffer in silence because they don't even know where to start the conversation. And the advice I'm giving you is just say it. Just say what's driving you nuts. And you may not be able to articulate what it is exactly, but if you're at a doctor who can actually understand what you're sort of saying, we can get there.
And it's not the patient's job to figure out. They're coming to you to figure out what's wrong with them.
Yeah.
So that makes sense. Yeah. And are there anything? Is there anything that, in terms of lifestyle, a patient or a woman can do to maybe ease the fibroids or the response during pregnancy, or making sure that they have a successful pregnancy, for example? Or?
So I saw this patient the other day who I adore. So she already has one kid from us. She's trying for her second kid. And I do her ultrasound. I see her, we talk about the pandemic, talk about how she was scared of COVID and how she locked herself up at home, just hung out with the baby. She's all of her fears and concerns of everything. And then I do her ultrasound in our exam room because it's just standard care of how we treat patients. And I'm like, so we need to talk about this big fibroid that's here. And she literally goes, oh, I knew it. I knew it, I knew it, I knew it. My doctor told me my vitamin D was so low, I knew I'd have a fibroid. And I was like, excuse me? And she's like, well, yeah, I knew it, I knew it. My doctor told me my vitamin D was low 2 weeks ago when I went to my internist. And she said it's okay because it was a pandemic, and that's why I have fibroids. I Googled it, I found it. And so I was like, okay, wait a second. There's a difference between association and correlation. As we get older, we know that people have an increased incidence of having fibroids, especially if you're black, brown, or Asian, right? We just know that those three big populations have issues with fibroids. We also, as you get older, your vitamin D status goes down because you're not outside running around and playing around. And oh, by the way, we had a pandemic and we locked people inside, so they were not eating healthy food, they were not getting sunshine, they were literally like sitting inside scared for their lives. So of course your vitamin D is going to be down. But this doctor didn't take that moment of education to say, why do you care so much about your vitamin D? And this woman just, of course, associated the two. At the end of the day, she'll probably come over here and get her fibroid removed. But regardless, vitamin D is not the cause of fibroids like everyone thinks it is. It is a association with other lifestyles, not just fibroids.
And look, and I think I'll add another layer to it too, is I think when we're talking about keeping a pregnancy or getting fibroids, I think that, I think that the purpose of this conversation when we talk about these things wasn't to say, hey, you can do these things to prevent this from happening. It's more about you can detect these issues early, you can identify what needs to be managed, what doesn't, and take the proper steps to hopefully live a happy and full life and achieve what you want to achieve in your reproductive life. But I think one of the greatest sources of stress that we have just as humans across the board is when we stress about things that we can't control, right? There's a lot of things that we can't control as humans. And as Dr. Levine was saying, right, just statistically speaking, yes, certain percentage of women will get fibroids. Certain percentage of us will, get high blood pressure or high blood sugars or cholesterol. And I think if you know what your tendencies are and you can plan for them, you can have conversations with people you trust who are going to give you good medical advice and help you navigate those choices and help you kind of plan according to what you're trying to achieve when you want to achieve it. I think that's probably the best way to approach it. But just trying to think of what my diet was on a given day. Not that we don't want you to eat well, exercise, take good care of yourself. Any doctor would, their self would want you to take good care of yourself. But there's not necessarily a direct correlation between that and whether or not you get a fibroid or whether or not you're able to keep a pregnancy.
I will also just share. There is a point where the doctor can overshare, right? So you have to know your audience. And I remember when I was in residency, and I trained up at Columbia, one of my junior residents walked into an exam room and told a patient, so I have good news and I have bad news. Well, by the way, you never actually want to hear that from a doctor. Like, that might work on Grey's Anatomy or whatever else, but you never walk in the room and be like, I've got good news and bad news. Which one do you want? Well, it sounds like you don't want either of them, right? Because why the hell are you talking about it? But the junior doctor walks in and she says, look, I've got good news and bad news. The good news is they're only fibroids. The bad news is we're going to have to do surgery to remove them. And when I was amazing when I watched the body language of the patient and I watched the reaction of the patient, and she had a complete meltdown. Because when you say surgery to a patient, out of context, they think a couple things. One, they think this automatically means a hysterectomy. We're going to remove their uterus and remove their capabilities to either have another pregnancy or even ever get pregnant. B, if you think about fibroids being incredibly common in the black and brown and Asian populations, those are the populations at the high risk for keloids. And keloids and scarring are a big concern of many people. So now all of a sudden you're saying you're going to have surgery that's going to be disfiguring and scarring potentially. And people don't realize it's just surgery. And the third is, the gross majority of people are deathly afraid of surgery. Even though it's incredibly safe and incredibly common, and there are people who spend their entire life training to give you drugs. Those are called anesthesiologists. Not the guy you went to high school with who somehow now has a very nice car. Right? He's a drug dealer. But anesthesiologists who are completely trained to do this, and everyone's scared of going to sleep because they're afraid they're not going to wake up.
They get a bad rap.
Oh yeah, absolutely. I mean, I will say that it seems like a very cushy job, and I wish I did it some days. It seems very nice. They seem to start their days at a certain time and end at a certain time, and they don't really have to take call on the weekends. But patients are deathly afraid of these things. So there's no such thing as, oh, it's just surgery. It's about saying that we have lots of ways we can help you. It is a whole spectrum, from surgical to minimally invasive to maybe just, by the way, observation, because yesterday you didn't know you have this and today you do, and tomorrow you can't forget about it, but maybe you don't have to do anything today.
So when it comes to, and maybe some of the people in the audience don't know, it sounds like there's invasive and non-invasive types of surgery. If it's too PG, or if it's PG enough or it's too graphic, can you share a little bit of what happens when you go in for surgery for fibroids?
So I don't don't do the invasive side, so I'll let him do that. I can end up on somewhere in the middle because he then does the other end of the spectrum too.
Yeah, look, I mean, I'd say that there's a few different treatment options when it comes to fibroids. There's often, let's say, 4 categories that are the main categories, and there's some other areas where we still experiment. One is, of course, you do nothing, like just conservative management. That can be on its own, and depending on the person, that can be something that they're doing. There's medication. The medication often is something that's used as a stopgap. It often works on inhibiting hormones in one form or another, either the hormone directly or the receptors that are connected to the hormones. You can either stimulate or block, depending on what our objective is and the type of hormone. But often those are short-term measures that we use for 3 months, 6 months at most, and there are often side effects associated with those treatments. But we will use them pretty effectively for periods of time. And then we have procedures. Those procedures are a category, of course, there's different types of procedures. We can often go in to remove the fibroids, which are called myomectomies. People often get confused about the types of myomectomies, and that's really secondary, because it really just depends on the location, depends on the size, depends on the skill of the surgeon. But we can often remove fibroids either by using a camera, going from below to a natural orifice, what we call a hysteroscopy. And that's really depending on the location of the fibroid. If the fibroid's within the cavity, then that's what we would do to remove it. There's also what we use when we go through the belly, and so we can do that either through cameras that we call laparoscopic surgery. It often involves us inflating the belly with air to create more space and to safely operate with essentially chopsticks, with surgical chopsticks. That's
Sushi
done.
in the back.
Different kind of body parts, but yes.
It does require dexterity though, like getting sushi.
Very true.
Yeah.
Very true. I wonder if there is a connection. But yeah, look, I mean, of course, hysterectomies are something that we like to leave as an absolute last resort, and that's often something that I think is done far too often. I think the latest statistics I was reading the other day was that 30% of all women who have hysterectomies have them for fibroids. And 20% of all hysterectomies, and this is just data that's pretty well established at this point, are thought to not necessarily be necessary. And so you think that 1 in 5 women who remove their uterus, they're considered to do that. That's something that certainly gives us pause as clinicians and surgeons. And then one of our other treatment options that I think has proven to be quite popular is something that's not done by us as joint surgeons, but by our interventional radiologists. And that procedure is called uterine artery embolization, uterine fiber embolization. And that's a minimally invasive approach that involves usually making an incision the size of a freckle. And it usually involves going in either through the wrist or the groin under camera guidance. And they'll literally go in under camera guidance and plug off the fibroids with these gelatinous embolics that are designed for this purpose. And the fibroids will shrink and ultimately reduce in size and reduce in blood flow and certainly improve quite a bit over time. And now there's also quite a few other areas where I think there's been some innovation and some study. There's ideas of using what's called high-frequency ultrasound, which is still something that's not really widely used. There's also other procedures that involve different ways to burn procedures, burn fibroids. But of course, there are different variations of what I just described. In terms of on the fertility side, of course, once the procedures are done, we would often, I would even say before the procedures are done, depending on the situation, a big part of our approach often will involve collaboration with the fertility specialist, because depending on the person, depending on what someone wants, someone may choose to get pregnant before they treat their fibroids, or treat their fibroids and then get pregnant. And so there's situations where we'll often lean on our colleagues for egg freezing or embryo freezing. And so let Dr. B take that one.
So I'm not afraid to use the word vagina. I think that's still PG. So natural orifice is vagina, just to put that out there. And so for us, when we're going after fibroids from below, it might be that we're going to freeze someone's eggs or embryos at the same time that they're asleep. We can actually go into the vagina, into the cervix, into the uterus, put some water in and shave them down. Sometimes you don't want to do that. And the old way of fertility care used to be, do the procedure that you're there to do and don't do anything else. Because the more you do, the more you put the patients at risk. Well, now we know that with the busy lives that we all have and through the pandemic, you want to consolidate care as much as possible. So a lot of doctors like myself have introduced doing minimally invasive surgery at the same time as doing other procedures like will retrieve someone's eggs to make embryos or to freeze their eggs and remove a polyp or remove a fibroid, remove a growth in the uterus. Regardless of how it happens, either before the treatment, during the treatment, or after the treatment, you still need to do a follow-up. You still need to get one normal cycle before you ever put an embryo back. So I always warn patients that, like a good novel, it has a beginning, a middle, and an end. And the beginning is typically the surgery, the middle is making sure that you're okay, and the end of the story hopefully ends with a baby.
Thank you guys for all that information. That was tremendously insightful. I want to lean in a little bit more about egg freezing.
Sure.
Could you share a little bit more about what that process is like?
Yeah. Thank you. So, egg freezing feels like it's all the rage these days, and that's amazing. But I remind patients that egg freezing is a rather new technology. It has only been commercially available in the United States since 2012. Prior to 2012, it was actually experimental. Now I just heard like a, oh my gosh, or oh, or something from the audience. And the reason is that IVF has been around for as long as I am old, right? I was born in 79, Louise Brown was born in 78, so it's 43 years old for IVF. So what the heck are we talking about when IVF is 43 years old and egg freezing is only 10 years old? And the reason is that egg freezing became commercially available in 2012 after we had a lot of research about freezing eggs. It actually took close to 8 years of consolidated research from lots of great places. Locally, it was places like NYU and Cornell, Columbia. Nationally, places like CCRM, where I work, our original office in Denver, UCSF in California, and all across the country of people looking at what happens when you freeze a single cell, an egg. You see, we've been freezing embryos for a long time, and freezing embryos means freezing a whole bunch of cells. We used to freeze them on day 3 when it was 8 cells. Then we started freezing embryos on days 5, 6, and 7 when there were like 100 to 1,000 cells. But freezing an egg is 1 cell. And what we knew that before 2012 was that some people were really good at it and some really weren't. And the reason we froze eggs before 2012 was, let's say, for example, on the day of IVF, the male partner has no sperm. Where the nice guy in the waiting room actually has the worst looking sperm possible, right? He looks like Michael Phelps on the outside, but on the inside is all Ryan Lochte. This guy got drunk and swam in circles in Brazil. But it's quite possible that happens on the day of collection when you're trying to go get eggs. So you had to have a resource out there of how do you save these precious eggs, right? This woman's gone through 2 weeks of shots and now is asleep, and you have these eggs that look great and the sperm that looks like dirt. And so what you used to try to do is hope for the best and just freeze it. And what we learned was that when we applied the techniques of freezing of eggs that we used for embryos, both those day 3 and day 5, the outcome was mediocre at best. Specifically, what we knew was that when you froze eggs using the technique of fast freezing or slow freezing, when they tried to wake them up, that's called thawing, they didn't really wake up with the same efficacy and efficiency that you were hoping for. 60%, 50%, 70% would wake up. I mean, can you imagine that you go in, you take all these shots, you spend thousands of dollars, and you only get, 40% or 50% of what you paid for? That's not good. Now, even today, there's no guarantee that the eggs you froze are the babies that you get at the end. But what we've done today versus what we did back then is we learned that that single cell, like most things in our bodies, is mostly made of water. And if we removed the water from the cell, that's called vitrification, we found that we could freeze eggs and embryos with great efficiency and efficacy, which means they would wake up really well and they would work really well. If you're not sure what I'm telling you about, think about all of you growing up, what was in the back of your mother's freezer. You would never eat it, so it stayed in the back of your mother's freezer, because it has freezer burn, right? Freezer burn is wherever you have ice crystals that form and they kind of break things down. That's what was happening to eggs before 2012. People who are using the slow freeze or the fast freeze were having ice crystal formation happen, and those ice crystals punch little holes in the membranes of the eggs. Well, now that we all vitrify, which is what happened in 2012, this recommendation came out, we all now can freeze eggs with great efficiency. However, eggs, like most things in this world, are very temperamental. And temperamental means it matters where you freeze them, how you freeze them, who froze them, the technique, and so there's definitely like centers of excellence, and we can go through that later, but I would say is egg freezing is the first 2 weeks of IVF. It's 10 to 12 days of shots. It's not a guarantee in a baby, but the doctor who's treating you should be able to say how many eggs you have frozen should yield how many lucky embryos at the end. even if the guy that you end up with looks like Michael Phelps on the outside and is Ryan Lochte on the inside. Don't mean to pick on Ryan Lochte. It's just easy to do.
No, that's really great information. And then in terms of freezing an embryo and a egg in of itself, it sounds like, and that was something that we discussed too, do you have a higher chance if it's an embryo versus an egg? And again, if you have fibroids, does that affect, is it
Great.
better to have
So-
an embryo?
Great question, right? So I get this question every day. You know, I go through this whole conversation, I like finally get my chance to like take a sip of water, and the patient's like, great, but I need to freeze embryos, right? And I'm like, we just talked about freezing eggs, like for literally like 18 and a half minutes. But there's still this preconceived notion that embryos are better than eggs. And my answer is, if you don't want to be shackled to someone, because that's what you're basically doing, is because you can't take the bullet out of the gun, right? Like, it is in there. Like, that is the two of you that makes that embryo, then don't make embryos. In fact, if you freeze eggs, you can still make embryos with that person. You can even guilt them into having to freeze sperm at the same time that you're freezing eggs. But you can't undo it. And what we do know is that from center to center, we see this variance as doctors who, you know, do secondary consults or tertiary opinions or whatnot. Every clinic, every center has different efficiencies. So you need to ask your doctor that question in a very open and honest way, and you asked it very openly, saying like, hey, do I need a sperm source to be able to get the most value for what I'm doing? Because it's the same 2 weeks of medications. It's the same, you know, procedure at the end to retrieve the eggs. But if you're looking for an outcome, say, is I want to protect and preserve my fertility, I want to like stop the clock, either to go get fibroids adjusted or removed, or potentially just to have a kid number 3 because you're already worried about number 1, right? I remind everyone, you freeze your eggs not for kid number 1, freeze your eggs for kids number 2 and 3, so you have optionality out there. And if that's who you are, then ask your doctor, is this for me? And if it is for me, are you the right one to do it? And if a doctor gets uncomfortable, like, I say you hightail it out, because no doctor should be uncomfortable in answering those questions.
And in terms of having, let's say, there could be a variety of things that can cause issues during conceiving. If someone does have, let's say, fibroids, or even if they had a miscarriage, would you suggest that the patient consider egg freezing?
So, it is not one size fits all. It's not like, oh, you have a uterus, it's gonna get a fibroid, freeze your eggs, call me. I mean, if you wanna call me, you can, it's fine. But, you know, in reality, I think it's an approach for people who want to protect and preserve their fertility. It's a very specific approach and a very specific technique. Now, we are seeing one of the weirdest things that we never imagined we'd see before. Amazing employer benefits. You can work for Google or Facebook or Uber or Lyft or McKinsey or Wachtell Lipton or any of these like super geeky places, not just tech places, and you could have a fertility benefit that includes egg freezing. So many women are like, why not? Why not freeze my eggs? Maybe I want to freeze my eggs now to donate them to my sister who might have trouble. Maybe I want to freeze my eggs now because I never thought about my fertility. This is my chance to like do a little pressure test of my fertility. Who am I to judge, right? Like, I don't have a crystal ball, and neither do you. Like, we know that fertility is the one thing that, you know, marches along with time. And so what we are seeing that we never anticipated before, and it is a good thing, by the way. Like, let there be no ambiguity. This is like the best thing ever that we live in a state where in New York, fertility care is a mandated coverage, right? Egg freezing is not mandated, but it's very easy to say to your employer, hey, it's discriminatory that I don't have a sperm source, that I can't protect and preserve my fertility, but if I had a sperm source, I could. Hint, hint to all the people out there. But it's amazing. If you want to freeze your eggs, you can stop the clock and do it. Just don't feel compelled to do it, because everyone else around the dinner table has already done it.
Yeah. Do you have anything to share, Dr. Gohan?
Yeah, look, I think it's fascinating. It's incredible to see the evolution that's happening, because I think we've seen this in our careers. Both Dr. Levine and I are similar age and similar stage in our career.
He's just taller and thinner and nicer. Yes.
It's being too kind, Dr. Levine. Look,
Taller and thinner and sort of nicer.
I think it's interesting to think just how much this has evolved, because you're absolutely right. Something has changed. And I think it's partly technology. I think it's partly mindset. I think it's partly insurance coverage, partly COVID. But I do think that there's a lot more thought given to reproductive health than I think has happened in previous generations. And I think it's a wonderful thing. So we really think about how we've evolved as humans. You know, so much of the world has evolved. So much of our lives have changed. We study more, we work more, we have a lot less time with our families. So I'm not saying that these are all things for the better. But if you think about like what the average age of like what the average person lived until, say, how many years ago, 2 years ago, I'd probably be one of the oldest people in town. And you know, I think, you know, while we're not elders, right, in this current, you know, world that we're in, our bodies, our biologies hasn't changed, right? So the fact of the matter is we weren't designed initially, you know, to be able to reproduce when we're in our 50s and 60s and 70s and 80s. And so that cutoff, that number has continued to shift. It's because of all the great work of people like Dr. Levine that this has happened. So it used to be, you know, 35 was it. Once you got 35, it was all, you know, extremely unlikely to occur. And that number now is becoming 40, maybe even 45. And that number's getting further and further, and I think it's because of just the abilities for us to be able to really customize care and approach things in a much more personalized way than we ever could before.
Yeah, I'll just say that, you know, the most annoying thing ever is when you look at someone's records from a hospital, and she's 36 years old. And I always say 36 years young, right? Because as someone who's 42, I'm always like, geez, I'd love to be 36. Like, sounds amazing. But when someone's 36 and it says, this elderly woman was trying to get pregnant, and I'm like, what the F? Like, 36 is not elderly, but it is this really misogynistic.
Actually, the diagnosis.
It's like misogynistic and discriminatory that we say that when you're over 35, you're elderly, and you're over 40, you're geriatric. And that's cool if, like, it's 1954 when the average age of death was, like, much less. But this is ridiculous that this is in our literature today. And by the way, this is insurance companies. These are the big insurance companies that push this, right? It's the continued, like, misogynistic behavior of insurance companies saying a woman is doing something high risk at 30, right? Like, there's this misconception that at 35 you're a high risk pregnancy automatically. At 35 you're my average patient, right? Like, and it's amazing to me that we are not very comfortable with that. Bless you. Sneezing on the truth. But it's important to also recognize that at 35, if you have a family history of fibroids, they're popping up. And at 40, if you have a family history of fibroids, you got them. And what I do think is that if we want to think about these time points, 32, which by the way, 32 is where you should really start thinking about your fertility, not 35, but 32, 35, 40, think about whatever else is going on. What's in the architecture? What's on the landscape? What else is there? It takes eggs, it takes sperm, it takes a uterus, it takes fibroids. What else is there that we can talk about to just, like, you know, go for the checkup? And oh, by the way, many people who come to me say, I haven't been to a doctor in 2 years. Can you go do my pap smear? Can you go change my IUD? Can you do this, that, and the other? It's been a pandemic, right? People haven't gone to the doctors. And so we might be their first line of their OBGYNs, and then we'll send them over here and be like, hey, you need to go get checked up because this is what I do in this little box. And you need to do that, all of you, right? Like, you need to go checked out.
It's like getting a haircut after the pandemic.
Yeah.
Hair color, haircut.
I would say hair color and haircut, right? Like, so everyone's like,
I certainly wouldn't know what that's
it's funny, I have this one patient who said to me, she's like, I got my first haircut after the pandemic. I had no idea I had gray hair. Like, what do you mean? And she's like, well, the guy's cutting my hair. And he's like, you have all these grays. What do you want to do about it? And she's like, go F yourself. I don't do anything about it. I didn't know I had gray hair.
Awesome. Thank you guys so much for all the information you guys shared. I want to open up to the audience for any questions that you guys might have for both Dr. Levine and Dr. Dover.
Do we know what are other risk factors contribute to the rising of development of fibroids?
You know, it's a great question. I don't think we do. You know, I think, again, you know, we've found certain patterns. So it's something that we know about after the fact. We have a good idea as to how it happens, but not why. And in fact, we've been looking for genes. We've been trying to find a specific gene. We haven't found it yet. And so I think there's all sorts of theories. I think, you know, people often look at, you know, certain you know, populations and look at, you know, what the differences are in different parts of the country, different parts of the world. But we really don't know, unfortunately. I think the one thing that we did notice, and I know, Dr. Levine, certainly I don't think vitamin D deficiency causes fibroids, but there's been some data out there that talks about supplementing vitamin D as a way to at least reduce the speed with which fibroids grow. But other than that, haven't read a whole lot of the cause and effect that we really have impact on. There's all sorts of theories. People talk about hair relaxers. People talk about hormones. People talk about antibiotics within the food chain. There's all sorts of theories that people have, but we haven't been able to prove it.
I'll also just say this. The ultrasounds we have today are so much better than the ultrasounds we had 10 years ago, let alone 30 years ago. I was talking with my mom, I don't know, a couple weeks ago, and she said to me, she's like, they didn't know if you were head up or head down when I was full term. So I went for x-ray pelvimetry. I'm like, Mom, you shot me full of x-rays before I was even born? But which explains so much. I don't need a therapist. I actually just need less radiation in my life. But in reality, we didn't know how to do an ultrasound back then to actually see, because they had what's called static ultrasounds, right? They would take a wand. I'm sure when your mom was practicing, they'd take a wand and they would just go back and forth over the belly and hope to see a circle that was the head.
It's like going through the TSA.
Right. and now, right, I can do a 3D ultrasound in my office. I can put saline in there and do a 3D ultrasound. I can tell you where your fibroid is, tell you if it's going to be a problem or not. And oh, by the way, your uterus is bent backwards and the blood flow is this, that, and the other. For the same cost as the machine was in the 1970s, right? Think about $75,000 in the 1970s was a lot of money. Well, the better we get at imaging, the better we get at diagnosing. The better we get at diagnosing is the more aware we are as patients. That's good. But it also means that people are more aware that weren't aware before. So I don't think that there's a rise in fibroids today versus there were in the past. I think there's better medicine. I think we're better at diagnosing things. We're better at seeing things. And maybe, I hope, we're better at talking about things.
Yeah, because I guess I'll just tell you why I'm here. I mean, partly for myself, because of my family history. My mother and her twin sister, and they were fraternal, both had very large fibroids, and both ended up choosing to have full hysterectomies in their late 50s because they just wouldn't stop having their period, and they had heavy bleeding. So I'm 40 now, and I didn't have any kids. So it's I'm starting to wonder, how is that going to affect me? Will I soon start developing fibroids? But I also work with pregnant women and women who want to conceive. So I'm also wanting to find out how I can support them too. So thank you.
Sure,
Yeah.
sure. No, thank you for coming and thank you for sharing that. I mean, it's certainly very, very tough and challenging, certainly. When you have loved ones who have conditions that you really have no control over. And I think, hysterectomies in the past were really the only tool we had. There's been so much evolution, I think, in medicine. And I think especially in these areas, I think over the last 10, 20, 30 years, I think the point on ultrasound is right on. I think often people wouldn't even know about these problems until they were big enough, and until they really cause enough problems where people really experience them. I think adenomyosis is a great other topic we haven't touched on today, but I think it's another great example. One thing I haven't talked to a lot about before, Dr. Levine, is just our love for ultrasound. I couldn't agree with you more how incredibly transforming these tools have really had an impact. Just how much it's changed the way we practice and the way we are able to discover things. So one of the first things I'd recommend is definitely seeing OB/GYN, getting an ultrasound, assessing the uterus, taking a look at your follicle counts, drawing some blood, and then maybe putting a plan together. Because I think there are situations where we're talking about the line between OB/GYN and the fertility docs, for lack of a better descriptor. And I think one of the things that we do, even though we will often work with patients on planning for fertility and checking to see whether or not there's any issues or problems, there are situations where we go straight to Dr. Levine. And I think once we start getting into 39, 40, 41, one of the biggest factors often that people I think underestimate isn't necessarily the fibroids. It isn't necessarily what option they're going to tackle for the treatment of fibroids, but in fact time. And so if we're in a situation where the window is getting more narrow, we're at 40, 41, to, I do think it moves one to be thinking just in terms of what their objectives are, what their timeline is, and then putting a plan that keeps all of that in place, because I think sometimes that can get lost in the shuffle.
So I'll just add, a picture's worth 1,000 words, right? And because we all live in New York, although I guess they could be watching from anywhere, the secret to a successful coat check at a nightclub is taking a picture of the coat check ticket that they give you, right? Because you have your phone on you, and you're
Unless
never
you
going
lose your phone.
Right, right.
Because you're
What's that?
Unless you lose your
Unless
phone.
you lose your phone, but then there's some bigger issues talking. But it's probably the best night ever if you lost your phone and you didn't realize it. But if you're going to try to get your coat at the end of the night and you're hoping to find that ticket in your pocket, you know that having a backup is the best way to, make sure you're not going to be cold when you go outside. If you go to the doctor and they see something, they find something, first of all, take a deep breath. Because it was there last week before you went to the doctor, right? It just happens to be that's when your appointment is. But number 2, take a picture with your phone of whatever they found. Be like, hey, can I take a picture? Or like, hey, can you print me a picture? Or hey, I know this sounds weird, but do you care if I just take my phone, just like take a couple pictures of what you see on the screen? And the reason is because whatever they tell you is going to go in one ear and out to your Google. Out the other side. And you're going to Google the first few words of what they said, and you're not going to hear the rest of what they said. And then you're going to call that guy or that girl that you're friends with who may have been a doctor, but you end up they didn't go to med school, and all these weird things happen. But you just want to be able to have some record of what happened on your phone. Because if you can go to your OBGYN and say, hey, remember last time we talked about this thing? Where is that thing? And what is this thing now? And your OBGYN might not even be able to pull it up right away and say, oh, it was 3 centimeters last year, and this year it's 3.1. Nothing to worry about. Last year it was 1 centimeter, this year it's 5 centimeters. Oh, you've had a lot of growth. So you do have to advocate for yourself. And I think, you have these unbelievable photo albums on your phone of all the pictures that you don't need and screenshots of things you never really should have bought. Take a picture of your fibroids, take a picture of your medical records, take a picture of whatever you can in your doctor's office. And by the way, it's your data, right? You actually own it. I am just the person who protects it for you, but actually you own your data. So I'd say advocate for yourself.
And I think she had a question in the back.
Oh, I have a couple questions. I'm a professional Googler. So on Google in my research about fibroid diet is one. So it is allegedly a correlation between diet and fibroids. So one of the things that I think about is if a woman goes through surgery to have the fibroid removed, and if she gets a fibroid again, isn't there a correlation between her diet and the fibroid growth?
So-
Because if she's continuously eating the way she was eating before the surgery, then
So I think first and foremost, welcome to our Googler Anonymous group, and I appreciate very much you giving us the background. No, all joking aside, I think to Dr. Levine's point, he was talking about the difference between causation and correlation, and it's something that we see so much as humans, right? In so many different parts of our life, right? It's so common for us to have something happen and associate with everything else that's happened around it, and try to draw connections. Because as humans, we're looking for meaning, we're looking for reasons. And that's not to discount the chance that there could be things that we don't know about. There's all sorts of things we don't know about in medicine. We're learning things every day. And things that we thought we knew, we find out it wasn't true, we go back and change it. Anyone who's paid attention to the news in the last 2 years has learned that the hard way. But when we talk about diet and fibroids, I do want you to know that it is a very it's a very unclear science. We have not found any correlation between diet and fibroids. And so again, any doctor that you go to wants you to eat well, exercise, take care of yourself, get sleep. These are the basic tenets of good health. But once you start thinking about, well, do I have to do a low carb diet? Do I have to do Atkins? Do I have to do this? Do I have to do that? Paleo? All these things are significantly impactful to your life. They're not they're not easy to maintain. And if you're making those kind of efforts, you at least want to make sure that they're connected to good health. You at least want to make sure that you are doing the kinds of things that are really going to actually have an impact, as opposed to just things that are more ritual based or more like superstition. And so I think the challenge is, I think, especially with the topic of fibroids, what I find is that there are a lot of non-medical communities out there that sell all sorts of products, whether they be detoxes, whether they be teas, whether they be one product or another. And I think, certainly if something works, I'm not discounting, non-traditional approaches, but if something works and it works for you and it's not harmful, fine. It's not a bad thing. Whatever makes sense for an individual, as long as it's not causing them harm, is okay. But it's important to keep in mind there's certain hot button topics, whether it be fibroids, whether it be sexual functioning, whether it be male pattern baldness, whether it be weight, that there are no shortage of businesses and entrepreneurs out there that don't necessarily have your best interest in mind, and who are looking to sell you a product that are really preying on those specific sore spots that we have as humans. And so I think one thing I would say is you want to, as much as possible when it comes to these types of with these types of situations, in my personal opinion, is know what the facts are, know the things that we really have studied well, and then recognize that there are other things that may not necessarily have a whole lot of science behind them, but maybe you're one of those exceptions, or maybe any one of us is an exception to the rule, and we find that there's one particular change that really makes a very big difference for us. And if that's the case, there's nothing wrong with it. It's not necessarily a one-size-fits-all.
So what you're saying is I don't have to be on a plant-based diet. I can continue eating complicated food.
I know that the plant-based versus meat-based diet is a huge controversy these days. I'm not a diet expert, so I won't get too deep in that.
Okay.
But I will say that there's definitely very little, if any, evidence that would support that either of those diets are better or worse for your fibroids.
I will say this: if you put me in a corner and there's like a gun to my head, and you're like, "Well, tell me, is there anything that matters?" 4 things that I tell people to avoid, which is the same as the fertility diet, which is white sugar, white rice, white wheat, and skim dairy products. If you're gonna eat dairy, stuff full fat. Right? Like just go for it, because we know that skim dairy has a lot of sugar because it has a lot of lactose in it. We know those 4 things, which are also the anti-inflammatory diet, which are also the endometriosis diet, which are also the hormonal regulation diet, which are also, like I said, the fertility diet, basically are telling you to stop eating things that have ingredients that you can't pronounce. Because you're going to find white sugar, white rice, white wheat, and skim dairy, and all of the things that have 25 ingredients out there. And we don't know what those things are.
That's actually a terrific point, Doug. I say this because I think it's a broader question than just fibroids. And we often talk about this even with pregnant patients. It's a very good, it's a great connection that this is like a broad general concept. And again, neither Dr. Levine nor myself are dietitians, but we've studied science, and we've spent our careers in medicine, and I think nutrition is one of those really undervalued, underappreciated areas. And I think that one of the pieces of advice I give to my patients, I say, look, I know there's all sorts of fads, all sorts of opinions on diet, and it's gotten very confusing, right? Anytime we turn on the news, it's something. But I think the best rule of thumb is eat food people were eating 200 years ago.
Eat food.
If it was food that people ate 200 years ago that wasn't made in a factory, doesn't come in a bright package, doesn't matter what the package says, no matter how confident they are that their package and everything inside of it is good for you, it's probably not that good for you. If it had to live at some point, and I know vegans and vegetarians are giving me a hard time about this, but if it had to live at some point, whether it was a plant or an animal or bread or whatever it was, and it actually was done the real way. It wasn't mass produced. You didn't have to have enriched flour. You didn't have to have bleached flour or skim milk or skim dairy products. Chances are it's a lot better for you than some of those things.
By the way, patients can push back on this all the time. The example I give them is Swedish fish are delicious. I love them.
I did too, actually.
They are neither Swedish nor made from fish, and they're fat-free, so how could they be bad for you, right? They actually advertise it on there, fat-free. And that was a fad, right? That was a fad in the early 2000s. Everything has to be fat-free. We do know that if you eat Swedish fish all the time, you are not going to be fat-free. right? And the reason is that when you eat a lot of Swedish fish, which are delicious, I fully support the eating of Swedish fish in moderation.
This was just, you can count this food.
I don't know, but they're delicious. I love them. But what we do know is that when you eat them, they do spike your insulin, right? Because it's sugar, and as the sugar goes up in your body, insulin goes up. And we know that insulin is an incredible growth factor. And so if you want to go back to your question of, is there any link between diet and fibroids, or diet and endometriosis, or diet and X, Y, and Z? What we do know, and if you look at some of the new stuff about longevity, which is keeping your insulin in check, this is why everyone takes now metformin, it's like diabetes drug to help like keep themselves healthier. David Sinclair is the big famous Harvard author that talks about this ad nauseum. If you want to know why Swedish fish are really bad for your fibroids, it's because it probably is giving your body too much insulin, and insulin is a growth factor, and a growth factor that causes you to store things and build things, and if you're going to build something, you can probably build a fibroid if you're predisposed to them. So that's why we tell people to avoid the 4 Ws. We are basically telling you don't spike your insulin more than you have to. I know we're going to get close on time.
And there's one last question I think Gina might have on.
Yeah, well, thanks so much. This is really informative. I had 2 questions actually, so I'll tell audience. So one of them is when it comes to fertility, actually, what are the pros and cons of pursuing like an endocrinologist for overall hormone health versus a very specific like fertility? Because like what you're saying about hormone like health has a large impact on just overall fertility and also the body in general. And the other question I had was related to health advocacy is, like a lot of data talks about large sample sizes, but if you have a single data point of just a long historical history, in those instances where they might kind of be fall on average for the general public, but they actually but for them it's considered abnormal, how do you advocate in those situations? So like, for example, like I'm kind of using a thyroid or a hormone issue, like if you suppose you kind of feel like you have a what is it? The thyroid hypothyroidism,
Too low.
something like that, yeah. Like in those instances, but the data shows that you are within the regular range. How would you get help advocate in those situations? So those are the 2 questions.
So I'll tackle the first one, and I'll
Sorry,
lead him
really
in.
tense.
And I'll lead him into the second one. How about that? So, it's funny. A couple years ago, my mom was like, "What do you do for a living? Like, what do you actually do?" And I was like, "Well, I'm a hormone doctor." She's like, "No. Like, what do you do? Like, does it look like little babies under the microscope? Do you like stitch them in there? Like, you glue them in there? Like, actually, there's a product called embryo glue, but no, we don't glue them in there." And she's like, "What do you do?" And I was like, "I figure out who people are, and then I figure out what they need. And I hope that what I'm telling them what they need is what they think they need, or at least we're prepared to hear." So when someone comes into the office, what I do is a quick top to bottom check. That's both blood work and an ultrasound and a physical exam. And we figure out who you are, and then we figure out what you need. And if you're there to freeze eggs, I'm still going to check your thyroid level. Why? Because if your thyroid's all over the place, and you're feeling crappy, and you're either really tired, or not so tired, or you're a little edgy, or you're like feeling out of whack, it's one of the easiest things for me to help you help yourself to go see an endocrinologist. But you just mentioned a great point. What if you come in and everything's just fine? And you look me in the eyes and you're like, "Do I need to do this? I really hate needles. Do I need to do anything right now?" And I might say to you, you need to do one thing. You can't get out here doing nothing. You need to do one thing. And by the way, that one thing is not pay. The one thing that you need to do is you need to make an appointment for follow-up. Because you can't draw a line without at least 2 points, right? So as you're saying is, yes, you need to have a continuum of care. Yes, if someone's on the too high or too low, it's easy to pick out what's going on. And so for me as a fertility doctor who has a deep respect for endocrinologists, which is how I am trained, right? I'm still trained to treat endocrinopathies. That could be your prolactin from your pituitary gland. It could be your thyroid hormone from your neck. It could be, growth hormone deficiency, which a lot of fertility doctors don't realize that they're even treating. It could be blood sugar control if you're pre-diabetic or diabetic. Typically what I'll say is you need me for a short part of your life, but you need an endocrinologist for the rest of your life. And so I'll refer them out to someone that I work with really easily to do it. and I kind of stay in my lane as a specialist that does certain stuff every day. But with that said, your OBGYN really should be the captain of that ship. I should not be that captain. I should just get to be the quarterback who gets to throw the touchdown when you really want to win the game at the end. But you need the captain to really call all the plays along the way.
Well, thank you, Doctor. I hadn't really thought of my job in this, but I think your point about advocacy is a good one, and I think one thing to keep in mind, because I think this is a broad answer that isn't just specific to thyroid hormones, is that if you feel like something is wrong and something isn't working, then I encourage you to keep digging. Ultimately, I do think that sometimes we can, we can miss things, right? Like I don't think that science is perfect. I think there's all sorts of scenarios where someone feels like something's wrong. The initial tests come back fine, but there's another issue that's going on that's separate that only gets discovered once you look into it a little bit more. And so I would ask you, what are your symptoms? What are the factors that are causing you to feel like you're hypothyroid? And if your thyroid hormones are normal, once, twice, 3 times, then I think it may make sense to come to see the captain and take a look with your OB/GYN, or go meet with an endocrinologist who's specialized in broader hormones, and take a look at the rest of your hormones, and take a look to see whether there are other causes that are causing some of the symptoms you have. But I think it really starts with what are the problems, what are the issues that we're looking to solve, and then we can get into what the details are that we're maybe suspecting they're causing that problem. So I think as physicians, one of the things I think that sometimes, I think there was a question earlier about what one can do to get the most out of healthcare. I would say that one of the hardest things in medicine, and this is across the board, this happens in hospitals, happens in medical practices, is labeling. Is once someone gets a label for something, it's really hard to take off. And if I had a penny for every time I had a patient who came into me and said, look, I had PCOS, who didn't actually have this condition, which is called polycystic ovarian syndrome. Once we actually dug into it and we did the proper evaluation and assessment, it's really quite common. And so I think this happens in other scenarios as well. So often what I recommend to patients is say, look, I have a problem with my cycles, or I'm having an issue with my energy levels, or I'm having an issue with, with my blood pressure. And then we go through a workup process, or we review other workup processes, and we try to put the pieces together. Because I think a lot of things in medicine are often investigative and collaborative, and something that, as Dr. Lee was referring to, requires a timeline, requires a test of time.
Awesome. Thank you guys for all the information. If you guys have more questions, we're going to wrap up. If you guys have questions for Dr. Levine at CCRM, you guys can reach out to him via email or phone call, and Dr. Gohar at UAE. If there's anything that we learned today, it's about empowering each other as women and getting as much information and education as we can. And I think the last thing we learned is to not go on Dr. Google. I recommend Reddit instead.
Reddit's even creepier. I'll just say this about Reddit. The woman or the girl that you went to high school with, who's like the creepy girl who no one spoke with, is now the moderator of your Reddit group. You didn't talk to her in high school for a reason. Why don't you trust her now for medical advice? That's my take on Reddit.
Thank you so much for coming.
Thank you so much.
So Amanda back there